All right, everyone, welcome back. Today we're diving into Chapter 4, Adaptation, Injury, Inflammation, and Repair, which is essentially the story of what tissues do when life happens to them. This chapter is one of those foundational ones. Everything we talk about later in disease processes, ischemia, necrosis, inflammation, fibrosis, all traces back here. Think of this as the origin story for pathology. And as histotechnologists, this chapter matters because these processes are not just theoretical. They directly affect what tissues look like, how they stain, and sometimes how cranky they are when they hit the microtome. So buckle up. Cells are going to adapt, fail, panic, clean up after themselves, and sometimes scar permanently, just like people. Before we get into the weeds, let's level set with what you should be able to do by the end of this section. You'll notice these objectives are very intentional. They move from recognition to comparison to application, which is exactly how your brain and your future lab work should function. You're expected to recognize the major cellular adaptations like atrophy, hypertrophy, hyperplasia, and metaplasia, and not just name them, but identify what they look like histologically. We'll also spend time distinguishing reversible versus irreversible cell injury, which is a fancy way of asking, can this cell recover or is it done? Necrosis versus apoptosis is another big one. And yes, they both mean cell death, but they leave behind very different messes. One is orderly, one is not so much. We'll cover acute and chronic inflammation, who shows up, what changes in the tissue, and why chronic inflammation is basically the best gift that keeps on giving, but in a bad way. Then we'll talk repair, regeneration versus fibrosis. And finally, we'll tie everything back to histotechnology practice, fixation, processing, staining, and slide interpretation. Because if it doesn't matter at the bench, it doesn't really matter. This slide is a quick reminder of something you already know, but that we sometimes forget once pathology enters the chat. The body is made of cells and intracellular substances, and those components are not static. They are constantly adjusting to meet functional demands. Cells plus extracellular matrix make up tissues, and tissues, arranged in specific ways, create organs. Structure supports function, and when structure changes, function changes too. Here's the key takeaway for this chapter. Pathology is what happens when structure can no longer support function adequately. Or put another way, when cells can't adapt successfully, injury and disease follow, and your microscope becomes the crime scene. Slide zooms down to the cellular level because pathology always starts here. You already know these components, but now we're thinking about them in terms of vulnerability. The nucleus and nuclear membrane control genetic integrity. So when you see nuclear changes like pynosis or kererexis later, that's a big red flag. The cell membrane is all about maintaining balance. Once that membrane loses integrity, things go downhill fast and often irreversibly. And then we have our organelles. Mitochondria are the power plants. No ATP, no survival. The endoplasmic reticulum and Golgi handle protein production and trafficking. Lysosomes? They're the cleanup crew, but if they rupture, they can become the problem. Well, for a histotech side note, many early cell injuries don't show dramatic architectural changes, but they do affect staining quality, cytoplasmic clarity, and nuclear detail. So if something looks off but subtle, trust your instincts. This slide looks embryology heavy, but I promise there's a reason it's here. All tissues originate from one of three germ layers, the ectoderm, mesoderm, or the endoderm. And knowing where tissues come from helps us predict how they behave under stress and disease. Epithelial tissues from ectoderm and endoderm tend to regenerate well. Mesoderm-derived tissues like muscle and connective tissue, well, not so much. They're more likely to repair through fibrosis. This matters when we talk about metaplasia, regeneration, and scarring later in the chapter. Fun but useful tidbit, Tissues that regenerate well are often the ones that drive pathologists and histotechs slightly crazy. Because high turnover means variability. Think GI tract, skin, and bone marrow. So why embryology feels like ancient history? It quietly explains a lot of what you see on slides today. This slide is your classic Big Four tissue overview. And while it may feel like review, it's actually setting the stage for everything that comes next in this chapter. We have epithelial, connective, muscle, and nervous tissue. And each one responds to injury very differently. That's key. Epithelial tissue tends to regenerate well. It divides fast, turns over fast, and generally bounces back like it's had a good night's sleep. Connective tissue is more about support and structure, which means when it's damaged, repair often involves fibrosis instead of true regeneration. Muscle tissue depends on the type. Skeletal muscle has some regenerative capacity. Cardiac muscle, not so much. Smooth muscle lives somewhere in between. And nervous tissue is famously dramatic. Once it's injured, recovery is limited, especially in the central nervous system. A histotech takeaway? Knowing the tissue type helps you predict what kind of changes you'll see, how severe they'll be, and whether repair will mean normal tissue or scar tissue. Zoom in on epithelial tissue because this one shows up everywhere, and it's a frequent victim of injury. Epithelia are all about protection, absorption, secretion, filtration, and sensation, which means they're constantly exposed to stress, like chemicals, friction, pathogens, you name it. A few key features to remember: epithelial cells are tightly packed, they sit on a basement membrane, and they do not have their own blood supply. That makes them highly dependent on diffusion, and therefore sensitive to ischemia. From a pathology standpoint, epithelia are also where we see metaplasia, dysplasia, and many cancers originate. Another histotech tidbit: epithelial turnover rates are fast, which is great for regeneration, but it also means poor fixation or delayed processing can really exaggerate these artifacts. Ever see sloughing epithelium and think, is this disease or did someone take their time getting it into formalin? Sometimes the answer is yes. And connective tissue is the unsung hero here of the body. It supports, binds, protects, transports, stores, and insulates. Basically, it holds everything together and cleans up after everyone else. This slide also introduces an important concept we'll keep coming back to: fixed cells versus transient cells. Fixed cells, like fibroblasts and adipocytes, live in the tissue long term. They're residents. Transient cells, like macrophages, lymphocytes, neutrophils, are more like visitors who show up when something goes wrong. This matters a lot for inflammation. Acute inflammation is dominated by transient cells, while chronic inflammation starts recruiting more long-term residents. Histotech note: connective tissue changes are often subtle at low power. Fibrosis, edema, and inflammatory infiltrates may not jump out immediately, but once you see them, you can't unsee them. Nervous tissue is all about communication: fast, precise, and unforgiving when something breaks. This slide separates central nervous system cells from peripheral nervous system cells, which is clinically and pathologically important. Neurons are excitable and transmit signals, but most of the support work is done by glial cells. Astrocytes maintain the blood brain barrier, microglia handle immune defense, and oligodendrocytes and Schwann cells deal with myelin. Here's the pathology punchline: neurons don't regenerate well, especially in the central nervous system. So injury often leads to permanent deficits rather than repair. From a histology perspective, nervous tissue injuries can be tricky. Changes are often subtle and timing matters. Early injury may not look dramatic, but function can be severely impaired. Slide wraps up our tissue review with muscle, skeletal, cardiac, and smooth, which each has its own personality. Skeletal muscle is voluntary, striated, multinucleated, and generally cooperative. It can regenerate to some extent, but severe injury still leads to fibrosis. Cardiac muscle is striated but involuntary, and those intercalated discs are critical for synchronized contraction. The downside? Cardiac muscle has very limited regenerative ability. Damage is usually permanent. Smooth muscle is non-striated, involuntary, and incredibly adaptable. It can hypertrophy and hyperplasia under stress, which we'll talk about more later. For a histotech tie-in again, muscle tissue is very sensitive to fixation quality. Poor fixation can blur striations, distort nuclei, and make everything look like smooth muscle, which is never the correct answer when it shouldn't be. Before we can really talk about injury and inflammation, we need to remind ourselves how normal fluid exchange works, because edema doesn't just appear out of nowhere. It follows rules. At the arterial end of the capillary, hydrostatic pressure is higher, so fluid is pushed out into the tissues. Think of it as pressure-driven filtration. The capillary is basically leaking on purpose. As blood moves towards the venous end, hydrostatic pressure drops, and osmotic pressure, mostly driven by plasma proteins, pulls fluid back in. Most of the fluid returns to the capillary, and the rest is picked up by the lymphatics. When this balance is disrupted, increased pressure, decreased proteins, leaky vessels, the fluid accumulates, and that's edema. Histotechnology relevance is that edema physically increases the distance between cells. That means poorer oxygen delivery, delayed healing, and sometimes pale, washed out tissues on H&E. If everything looks swollen and empty, capillary exchange has slightly gone rogue. Slide introduces one of the most important concepts in pathology, that healing is not one size fits all. When tissues heal by regeneration, the original cells proliferate and restore normal structure and function. This is the gold standard. Everything looks like it did before the injury. When healing occurs by repair, connective tissue fills the gap instead. That leads to fibrosis and scarring. Function may be partially restored, but structure is altered permanently. Whether a tissue regenerates or scars depends heavily on cell type and extent of injury. For a histotech insight, scar tissue is collagen-rich and cellularly sparse. It stains differently, feels different at the microtome, and once you see fibrosis a few times, you'll recognize it instantly. This slide explains why some tissues regenerate beautifully and others don't. Label cells, like skin, GI epithelium, and bone marrow, divide continuously. They're always ready to replace themselves, which is great for healing, but it also makes them more prone to abnormal growth. Stable cells, like liver and kidney cells, usually sit quietly until injury occurs. When needed, they can re-enter the cell cycle, but if damage is severe or prolonged, healing shifts towards scarring. Impermanent cells, such as cardiac muscle cells and neurons, do not divide once mature. Injury here means loss. Replacement happens with connective tissue, but not new functional cells. That last line at the bottom is important. Most abnormal growth occurs in tissues with label cells. High turnover equals high risk. Now we officially enter cellular adaptation. This is where cells attempt to survive without dying. Adaptation can be physiological, like muscle hypertrophy from exercise, or pathologic, like changes due to chronic irritation or hormonal imbalance. Because this distinction matters. Let's take a minute to review those two terms because, again, distinction absolutely matters here. Physiological adaptation is the body doing what it's supposed to do. It's a normal response to normal demands. Besides muscle hypertrophy from exercise, think uterine enlargement during pregnancy or bone marrow ramping up red blood cell production at high altitude. No injury, no disease, just the cells adjusting appropriately. Pathologic adaptation, on the other hand, is a response to abnormal stress. The cell is trying to cope, but the stimulus isn't normal or healthy. Examples include cardiac hypertrophy from chronic hypertension or metaplasia in the bronchi due to smoking. Hyperplasia driven by hormonal imbalance as well. The key point, both are adaptive, both are reversible, but only physiologic adaptation is beneficial. Pathologic adaptation is the cell waving a yellow flag saying, I'm compensating, but this could go bad if it keeps going. Again, I can't stress this enough. The key idea here is that adaptation is reversible. If the stress is removed, the cell can often return to normal. If the stress is too severe, too prolonged, or the cell simply can't adapt, injury follows. Think of adaptation as the cell saying, I can work with this. Injury is when the cell says, I absolutely cannot. For histotech tie-in, the adaptive changes often show up as changes in cell size, number, or type, not outright necrosis. These are pattern recognition moments at the microscope. This slide pulls everything together by showing the major types of cellular adaptation. Hypertrophy is an increase in cell size, not number. Think skeletal muscle fibers getting bigger with exercise or cardiac muscle thickening in hypertension. Hypertrophy is a decrease in cell size, often due to decreased use, blood supply, or even nutrition. Immobilized limbs are the classic example. Hyperplasia is an increase in the number of cells. This only happens in tissues capable of division, and yes, it's often hormone driven. Metaplasia is a change from one adult cell type to another better suited for stress. It's reversible, but it's also a warning sign. Dysplasia is abnormal growth, disorganized, atypical cells. This is where we start getting uncomfortable because dysplasia can be a precursor to malignancy. A little histotech pearl here is these changes don't occur in isolation. Chronic stress can push tissue along this spectrum. Adaptation, injury, irreversible change. Your job is often to help identify where on that path the tissue currently sits. Right. This slide is your visual cheat sheet for cellular adaptation. Think of this like cells responding to life stress the same way we do. They either shrink back, bulk up, multiply, change careers, or get a little weird. On the left, we've got atrophy, cells getting smaller. This is the cellular equivalent of I stopped going to the gym. On the right, we have hypertrophy, cells getting bigger, not more numerous. Think bodybuilders, not crowd control. Below that, hyperplasia, more cells. Same size cells, just more of them. This only happens in tissue that can actually divide, so keep that limitation in mind. Then we have metaplasia, which is cells saying, this environment is hostile, I need a different skill set. They swap one mature cell type for another, that's better, suited to survive. And finally, dysplasia, the problem child. This is disorganized growth. Cells lose uniformity, the nuclei look funky, the architecture falls apart. This is where we start raising an eyebrow clinically. Histotech tidbit is dysplasia is where your nuclear detail, crowding, pleomorphism, and staining quality really matter because subtle changes are the whole story. This slide shows the decision tree of cellular survival, and cells are surprisingly optimistic, at first anyway. We start with a normal cell in homeostasis. Everything's balanced, ATP flowing, membranes intact. When stress hits, cells try to adapt. That's the fork in the road. Adapt successfully and life goes on. Cannot adapt and we suffer cell injury. If the injury is mild and temporary, we get reversible injury. Think swelling, fatty change. Not great, but salvageable. If the injury is severe or prolonged, we cross into irreversible injury, and that's the point of no return. From there, the cell dies either by necrosis, which is chaotic, inflammatory, and messy, or apoptosis, which is tidy, programmed, and controlled. So the key takeaway here is adaptation is reversible. Injury can be reversible until it isn't. That timeline matters a lot. Slide answers the question, what actually hurts? First up, oxygen problems, which are huge in pathology. Hypoxia is not enough oxygen. Apoxia, or anoxia, is no oxygen. Ischemia is no blood flow, which is worse than hypoxia because nutrients and oxygen are both gone. And then ischemia usually comes with friends, like thrombus, which is a clot that stays put, or an embolus, which is a traveler that blocks something downstream. Then we have nutritional derangements. Too little and cells starve. Too much and the cells drowned in access. Carbon monoxide poisoning is sneaky. Oxygen may be present, but hemoglobin can't deliver it, so cells suffocate in a room full of air. And finally, immune reactions. Sometimes the immune system is helpful. Sometimes it's like, I will destroy everything to fix this. Allergies, autoimmune diseases, transplant rejection. Friendly fire is real. Bottom line, different causes, same outcome. Cell injury or death. Physical agents are the most intuitive causes of cell injury, the ouch category. Burns denature proteins, trauma disrupts membranes, frostbite and hypothermia break enzymatic systems, which enzymes are very temperature sensitive divas. Electrical shock interferes with ion gradients, which cells absolutely depend on. Radiation damages DNA directly. And then there's mechanical injury, which ranges from repetitive stress to, bear attacks. This image is here for one reason. It's to remind you that mechanical injury doesn't have to be subtle to be catastrophic. A histotech tie-in. Physical injuries often lead to necrosis, inflammation, and eventually repair with fibrosis, which you'll recognize histologically as dense collagen replacing normal tissue. Last category, chemical and infectious agents, and these are incredibly relevant clinically. Chemical agents and drugs, including pharmaceuticals, dose matters. The difference between therapy and toxicity can be very narrow. Environmental toxins, even normal substances like oxygen, water, glucose, and salt, when out of balance. Yes, even oxygen can be toxic. Cells really want just enough of everything. Then we have drugs of abuse, which often cause chronic cumulative injury, especially liver, brain, and cardiac tissue. And finally, infectious agents. Bacteria, viruses, prions, which are terrifying and not alive, fungi, parasites. These injure cells either directly or indirectly by triggering inflammation. A key takeaway here, cells don't care why they're injured. They respond the same way. Your job, especially as a histotechnologist, is recognizing how that injury shows up under the microscope. A big picture reminder, physiologic equals normal, expected, adaptive. Pathologic is abnormal, harmful, and potentially progressive. Same processes, different context. And context is everything in pathology. Slide is where everything we've talked about so far really comes together. Cells don't usually go from totally fine to dead instantly. There's a window of opportunity where injury can still be reversed if the stressor is removed in time. On the left, you're looking at normal kidney tubules, organized, open lumens, clean nuclear detail. In the middle, reversibly injured cells. These cells are stressed, swollen, and unhappy, but not doomed. You'll notice things like chromatin clumping and membrane blebbing. The key point? The nucleus is still intact. On the right, irreversibly injured cells. This is the point of no return. Nuclear fragmentation, membrane disintegration, and loss of cellular detail. A histotech pearl, when the nucleus is gone or shattered, recovery is off the table. No nucleus equals no comeback tour. Let's slow down here. This slide matters. Necrosis is abnormal, uncontrolled cell death. It usually affects groups of cells, happens because of injury, and it's always pathologic. The cell swells, organelles swell, the plasma membrane ruptures, and everything leaks out at once, which is exactly why inflammation is always present. Necrosis is caspase independent, messy, and it damages surrounding tissue. Histologically, necrotic cells become intensely eosinophilic. That classic bright pink you'll start recognizing very quickly. Apoptosis, on the other hand, is controlled and purposeful. It usually affects one cell at a time and is often a normal physiologic process. This pathway is caspase dependent. The cell shrinks, chromatin condenses, membranes stay intact, and the cell breaks into neat apoptotic bodies. No leakage, no inflammation, no collateral damage. Think of it this way. Necrosis is chaos. Apoptosis is cellular housekeeping. This slide defines necrosis in plain terms, and it's important not to overcomplicate it. Necrosis results from irreversible injury. The cell didn't adapt, it didn't recover, and now it's done. It's rapid, uncontrolled, and messy. Proteins denature, enzymes digest the cell from the inside, membranes lose integrity, and then the contents leak into the surrounding tissue. And that leakage, that's what triggers inflammation. Here's the critical point. Inflammation doesn't just clean up, it can cause collateral damage to nearby cells and tissue. From a histotech perspective, necrotic tissue often stains more intensely pink on H&E due to protein denaturation. Once you see it, you can't unsee it. This slide is a roadmap. These are the patterns necrosis takes, depending on the tissue type and cause. You don't need to memorize these yet, just start recognizing the logic. So coagulative, the structure is preserved, cells are dead. Liquefaction, tissue turns to liquid. Caseous or caseous, crumbly, cheese-like. Then there's fat digestion and sponification. Gangrenous is ischemic tissue, wet or dry. And fibrinoid, which is immune-mediated vessel injury. And the reminder at the bottom is non-negotiable. Necrosis is always associated with inflammation. If there's no inflammation, it's not necrosis. Full stop. Mic drop. This is the most common type of necrosis, and you'll see it a lot, especially in solid organs. Coagulative necrosis is usually caused by ischemia, loss of blood supply. What's interesting is that the tissue architecture is initially preserved for about 1 to 3 days. The cells are dead, but the outline remains. Why? Because ischemia inactivates enzymes that would normally digest the cell, so everything just freezes in place. Inflammation comes later, when neutrophils and leukocytes arrive and release lysosomal enzymes. Eventually, phagocytosis clears the dead cells. Classic organs are the heart, kidney, and the spleen. Histotech tip: if the structure is still recognizable but the nuclei are gone or fading, you're probably looking at coagulative necrosis. So reversible injury equals stressed but salvageable. Irreversible injury equals death pathway as activated. Necrosis is uncontrolled, inflammatory, and messy. Apoptosis is controlled, quiet, and intentional. Slide adds the pattern recognition layer to coagulative necrosis. One of the hallmark features is the wedge-shaped pattern, and that shape is not random. It directly follows the distribution of the affected blood supply. Wherever the vessel went, the injury followed. Grossly, these areas appear pale compared to surrounding tissue. That's ischemia making itself visible to the naked eye. Microscopically, this is where your histotech brain should light up. Cells are anuclear, the nuclei are gone, The cytoplasm is intensely eosinophilic. And here's the classic rule you absolutely want to remember. Coagulative necrosis occurs in all solid organs, except the brain. The brain is special. It does its own thing, always. Slide is basically a before and after with receipts. On the left, grossly, notice that wedge-shaped pallor again. Textbook ischemic injury in the kidney. On the right, microscopically, look at what's circled. Areas with intact nuclei is viable tissue. Areas with loss of nuclei equals dead tissue. What's important is that the tubular architecture is still recognizable, even though the cells are dead. That preservation of structure is the defining feature of coagulative necrosis. Histotech tip: when you see preserved outlines but ghost-like cells with no nuclei, coagulative necrosis should be at the top of your differential. Now we shift gears completely because liquefactive necrosis is the opposite vibe. Instead of preserved architecture, everything is digestive. Liquefactive necrosis happens when enzymes, from lysosomes and neutrophils, completely break down dead cells. There's no scaffold left behind. This is classically caused by severe bacterial or fungal infections or ischemic injury in the brain. That brain exception again, remember, the brain does not coagulate, it liquefies. The end result is tissue that becomes soft, liquid, and viscous. Think pus, not structure. If coagulative necrosis looks frozen in time, liquefactive necrosis looks like it melted. Slide shows you what liquefactive necrosis looks like at both levels. Grossly, the tissue appears soft and semi-liquid. There's no firmness, no structure. Microscopically, cellular outlines are lost. There's abundant debris. In infectious settings, you'll see tons of neutrophils. This pattern is commonly seen in brain infarcts, sites of bacterial or fungal infections. And when infection is involved, liquefactive necrosis can form an abscess, a localized pocket of pus. So reminder, pus equals dead cells plus enzymes plus inflammatory debris. Not magic, just pathology. Slide really drives home why the brain is different. After a cerebral infarct, like a stroke, the affected brain tissue doesn't scar the way other organs do. Instead, it undergoes liquefactive necrosis. Over time, the dead tissue is removed, leaving behind cystic spaces. That's why old brain infarcts often look like holes. Microscopically, you'll see loss of normal neural architecture and heavy infiltration of inflammatory cells. There'll be gradual cleanup by macrophages as well. On a histotech note, brain tissue already has a delicate architecture, so when it's lost, it's really lost. This is why neuroslides often look chaotic after injury. All right, this is a great place to pause. We've covered adaptation, injury pathways, reversible or irreversible injury, necrosis versus apoptosis, and then two major necrosis patterns. Take a breather, let your brain liquefy just a little, but not completely, and we'll pick back up shortly.